Good morning. My name is Miles Landry. I'm a general surgery resident at the University of Tennessee Medical Center in Knoxville, and I'm really excited to bring our findings from the introduction of cognitive behavioral therapy into the treatment of chronic groin pain. I have nothing to disclose personally. These are the disclosures of our senior author. Now, a quick word on chronic groin pain. Generally defined as pain lasting greater than 3 months, this can be expected to occur in up to 25% of our patients, with severe disabling pain occurring in less than 10%. We generally quote 5 to 6%. But when you take that against the more than 700,000 inguinal hernia repairs performed annually in the U.S., that still represents about 40,000 patients that are left with severe pain, few treatment options, and few clinicians that are really working towards a better understanding and treatment of this. Cognitive behavioral therapy has been around for a few decades. It's a psychotherapeutic treatment option that is available for treatment of addiction, pain, anxiety, depression, and we've recently seen growing evidence that it can be effective for post-surgical patients. Even though it has roots in the behavioral sciences, it's been supported by neuroscience with recent studies showing actual changes in gray matter and neural rewiring, which represents the way that our thoughts actually can influence the biology that we're dealing with. So CBT is a technique of multiple sessions that give patients a better understanding of the biologic, psychologic, and social factors that influence the way they perceive the world. By giving them tools to better address their behaviors and thoughts as well as their emotions, we can help impact the perceptions they have of pain and the development. We have patients see a minimum of 3 to 6 therapy sessions with a local clinician in their area that's been vetted for the treatment of surgical patients. And why are we talking about it? Well, we found that while researching our inguinal hernia problems, we weren't coming up with the right answers. Quite frankly, the routine, normal statistics and evaluation were inadequate for dealing with these complex issues with multiple different problems, all trying to find the one right answer. So we went to complex system science, which gave us tools like optimal variety, letting us understand that there are certain techniques that are going to be better for specific patients in specific settings and no one right answer for everybody. The same can be said for chronic groin pain, which is multiply complicated with lots of different techniques being tried, and we're not sure who's working for which problem and which one's best yet. So we turn to continuous quality improvement as the tool to help define and figure out how all of these different variables work within a dynamic process complex adaptive systems represent. A quick word on IRB. CQI is not considered human subject research and as such is inappropriate for IRB approval. Furthermore, recent publications have suggested that this is a valuable method for evaluating the quality of the care we're providing and should be utilized going forward. Our technique focuses on a patient-centered multidisciplinary team, which takes into account the patient's family, care managers, everybody involved in their care to look for different avenues for improvement. And what we hope to create is a shared decision process with the patient at the center, and if we can create that, we'll have better engagement and hopefully better results. For our statistical analysis, we did use a combination of traditional statistics as well as principal component analysis or factor variance. This is a way of looking at all the variables within a complex system to define what's causing the most variance. In terms of results, we've looked at 129 patients over the last 7 years. Our demographics are roughly equivalent. For patient factors, I think one of the things that jumped out immediately was the development of their chronic pain, with nearly 60% noting that it developed immediately, but 40% noting a delayed presentation of it. This clearly looks like different groups and is a very good avenue for future study, as there's something fundamentally different we feel about these patients, and they're likely to respond to different treatments. In terms of treatment factors, we were able to complete 60% of our cases on an outpatient basis. Additionally, 27 of our patients underwent preoperative CBT at this point. Overall, 13.9% of patients reported new postoperative pain. That's pretty distressing in the fact that we're operating on these patients to try and relieve chronic pain, and we're actually creating a new pain. So clearly an area of need that we're trying to find who we can benefit the most. For patients' chronic pain, about 11% had no improvement in their symptoms. So we've created a procedure, put risk of new pain and not cured it for a portion of our patients. We think that these are the people we're trying to find better treatment options for. Now, when we look a little deeper into this, we noted that none of the patients that underwent preoperative CBT experienced new postoperative pain, which we think highlights how CBT can be used possibly for preventative measures, as it had a profound impact during this study period. When we look at pain improvement, our patients that didn't receive CBT training, we had 15 patients that had little or no improvement, with 46 patients that had near complete resolution. Compare this with our CBT group, where every patient that underwent preoperative CBT had improvement in their symptoms, with about 60% of those patients having complete resolution, compared to 45% of the no pre-op group. So at this point, we really feel CBT has a benefit, whether it be in preventative, but also in treatment and effect of helping patients understand how pain works. Lastly, the procedures were able to be performed on an outpatient basis in all of our preoperative CBT patients, but this may have more to do with the recency bias, as we'll comment on shortly. Overall factor variance, we found the combination of intraoperative block, low pressure pneumoperitoneum, outpatient surgery, and CBT accounted for 27% of all the variability within the system, and we plan to carry those three variables forward into future iterations as we feel they're valuable. So discussion, what mattered? CBT had a clear impact on the development of new postoperative pain and seemed to be very beneficial in the relief of their chronic pain. Whether or not this actually contributes to them being performed on an outpatient basis is up for debate. We feel it can certainly help, but so do other interventions, as we previously mentioned, such as long-acting local anesthetic, intraoperative tap blocks. So that may continue for all of our patients going forward, we hope. A quick word on limitations. The biggest problem with continuous quality improvement is that it is very specific to our institution, our patients, our healthcare environment, and may not be reproducible for you. But as always, we will continue to evaluate our outcomes and see how this influences us going forward. Future avenues of improvement. At this point, we feel that a robust rehabilitation program should be incorporated in surgical practice. There's growing evidence across all fields of surgery that this is beneficial for patients and will have the best outcomes. We feel that cognitive behavioral therapy could be a valuable adjunct as well, whether it be for treatment or prevention. In conclusion, chronic groin pain is a real problem. It's a big problem, and we're going to see more and more of it. There's few clinicians that are willing to take these patients on, as they can be very difficult, and we feel that the inclusion of CBT within a robust rehabilitation program is valuable to improve our outcomes and our patient care. Thank you very much. I'm happy to answer any questions you may have.